Hello, everyone.
Hi.
Welcome and thank you for being here on time.
Hi.
Hello.
Yo,
Ya tengo los libros.
you got the books?
Yeah,
Yes. Good, good, good.
I got it.
So now it's gonna get serious. Okay, like always, we're gonna give a couple of more minutes for everyone to get here. Okay?
Okay.
Thank you.
Ay, es una historia linda que la publicó Heidi, la de Anadelia, de un tal Carlos Lazo, que vive aquí.
Ah, mejor.
¿Eh? ¿Qué?
Ahora te digo.
Dime, Cris.
Carlos Lazo es de Puente de Amor.
Sí.
Que está con el gobierno de Cuba.
¿Sí?
Que ni se le pone el problema de esto y lo otro.
Pero mira, pues tiene su forma de ver la vida. Mira, Paco publicó la foto de Juan Carlos. ¿Y esos puentes de amor qué cosa es? ¿Una página?
No, un programa que tiene hecho para viajar a Cuba y esas cosas.
Ah.
again, people. Thank you for being here. We should be able to start now. I just saw one student going in and out, and one student that's about to come in. So 1-2 minutes, and we're gonna start. Okay.
Cristiancito, ¿estás ondeando?
No. Bien.
Ay, qué bailó con él. Wow.
Algo.
Voy a poner una almohadita ahí abajo,
Cuando
en el asiento ese muy duro.
estamos
Era eso que dijo.
Okay. Hello again. Let's actually get this started. So now we have also a group.
Dime, niño, ¿qué hay?
Anybody else a chance to get here, but we are going to start.
No, llama la atención,
How's everyone doing?
llama atención del cliente, al servicio al cliente,
Why is not
y dile
this?
que está lloviendo mucho y ya, cuando te coges ya, viras para atrás, dices que vas a entregar la carga y ya, y punto. Y viras para atrás, entregas toda la carga y ya te vas y te lo pagas. Sí. Ya, llama y ya,
No.
atención. Dile que está lloviendo mucho y que no está escampando y que nada, ya, vira para atrás, entrega. Dale.
Too many things open at the same time. Let me see if I could just do this. Okay, this does not want to cooperate today, so. Gosh. Okay, let me know if you can see my screen. Or when you can see it.
Yeah.
Yes, we can see it. Well, I can see it.
Thank you. Okay, so this is what the section that we were covering last time. We started talking about CPT and how it goes. We show a few of the different types of ways that we can go through the CPT. We started going through the different parts of it. This is a PowerPoint. It looks a little bit different than the that we were doing before. A little bit more condensed, so hopefully it will work a little bit better. Just as a kind of a review of what we did last time, we said that the CPT stands for current procedure terminology. it is the procedures codes and procedure codes are reported into the insurance claims. It's published by the American Medical Association. It's published every year, and you can use it in any type of facility. We have all the way from inpatient, outpatient, hospitals, doctor's offices, anything that uses that. Anyone that can provide a service that will be that could be billed. So again, some specific things are things that we need to remember. One of the things that we should remember all the time. Let me see if I can do this. There you go. One of the things that you have to remember is that for what we call professional billing for inpatient, for hospitals or anything like that, the individual that provides service is really important. So the services can be provided by a nurse, can be provided by a medical assistant, they could be provided by a doctor, it could be a pharmacy, it could be a group of surgeons, whatever it is. But really important, in order to do that, to know who did it and know where you did it, you need to figure out what the document or the documentation says. Part of the documentation will be the thing that is going to help in the proving and certifying that medical necessity is needed. So when you're submitting a claim, you need to know that the why are we doing that procedure, as the ICD-10 code has to match and has to provide some sort of verification that the medical necessity is there. Okay, sorry about that. So when we're doing a reimbursement, one of the main things that you need to know is this going to get paid? And they might need different things. Not only the CPT code and the ACD code. Maybe they need authorization, pre-authorization. Maybe they need to send the clinical notes. Many different things that might be needed. So you need to know that those two things, ICD code and CPT codes, have to match, and that you're gonna get paid. Now, remember, what gets paid is the CPT code. The CPT code is the one that has the what we call the money attached to it. Okay, it's not the ICD. I don't care if you have a heart attack or if you have a broken finger. If we do an EKG, if you do an X-ray, if you do that procedure is the one that has the money attached to it. So the money will always be the same if we do the same procedure. Now, why are we doing the procedure? It could be different. So that's something that you need to take into account when you're doing all your things. Somebody else came in. Oh, now we have all the Franks there. Perfect. Thank you. Now, one of the things that you need to remember is that when we're doing the visit, more than anything else, the 99 codes, we need to know how much time, how much effort, how much intensity. I like the word intensity. The physician's time, the physician intensity in providing a service. How complicated the thing is. How complicated the medical decision making is. How many systems are we going to be reviewing? The more we can prove, the more we can bill. The more time, the more money we can get from it. Okay. So again, it doesn't really matter at the beginning. You are going to work in places that are going to give you the actual codes. 99213, excellent. Now, the thing is that you are going to tell them, hey, this code works or it does not work. And by you telling them what works and what don't work, you will be able to see if they are going to pay or not. So you can always, uh, tell the doctors, hey, you're coding something below what you should, what you should do. We should code for this one, or you're coding something too much. It should be too little. You know. So again, there's some other things that are taken into account, and then so the payments or payment components are going to be multiplied by some conversion factors and geographical adjustments. So I think I showed you already in the CMS.gov how codes can change the pricing if they are in one location or another one. Simple. The higher cost of living in an area, the more the codes are gonna pay, or the more expensive it's gonna get. Basically, that's what he's saying. We move through this. Hopefully, we can do it a little bit simple. We talked about the category ones. We have five characters in the CPT codes for procedures, services, and the descriptors. We put them in the sections, and all the sections have different areas. Then we have the category 2 and 3 that are for more for performance measurements, and then 3 for emerging technology. So again, the example that we always give the students is anything new comes in the middle of the year, we're not gonna wait until next year just to build for it. We're gonna start using it, and there's always codes for them. We now are gonna go over the chapters: evaluation management, the 99s, anesthesia, the first few, surgery, a big section of it, radiology, pathology, and medicine. Remember that you have some 99s in different locations, but most of them are gonna be 99 codes are gonna be evaluation management. So a 5-character numeric system for the CPT, and it will give you a whole description of it. It could be a complete code, or it could be an indented code, so it will show like a standalone code, or a code that needs something else. We went through this already. Again, we talk about the appendix. We talk about the modifiers. We mentioned all of the modifiers. This is something that we didn't saw like in one page only. I want you to look at this and kind of memorize them. Why? Because even though we went through all of them, and we went through the numbers also, they are the symbols that there's no other way that you can get them. So you can memorize them, you can get them from the book and understand what they are. But in the exam, they will ask you at least for 2 of those. Always they do. They always ask 2 of those. So pick one random, and they say, hey, you have a bullet, it's a new code. You have the cross, add on. You have the lightning bolt, FDA approval. Like they can ask you, and the question could be, a bullet sign in the CPT book means what? Option A, B, C, and D. New code, whatever, new code. Okay, so make sure you remember that. So this is kind of how we were showing you the example that we showed you last time. Same one. In this case, the section is surgery. The subsection is what part of the body it is, or what system it is. This case is integumentary system. Category from the integumentary system, skin, and then what are we doing? Incision and drainage. Okay. If it's excision, it's something else. So incision, you have to be careful with the actual spelling of the words also. Code number for that one, boom, 100 and then 40. Okay. Acne surgery, and then it tells you what types of things that we could do it. So we're actually popping a pimple here. 10040. So we continue, we keep moving to the different areas, and the next area that we're going to talk about, again, I'm going kind of fast over these things because we already talked about them. The guidelines always going to be at the beginning of the CPT section. They're going to tell you what to use it. Always try to read them, and again, you don't have to read the all the things all the time. Remember, you're gonna be doing this by doing the same codes over and over again. So by using the same codes over and over again, you memorize what are the guidelines for each one. So that's an advantage that you have there. Um, and then unindented notes, indented notes, you need to read them. You need to make sure that all the words that you have there are possible. So again, blocked indented notes, again, it will tell you a little bit about what it is and the system. And the indented one, you basically said some of the things are gonna be here. So for other medical lab, for other radiology, see this different number. So go to something completely different. And then that's how you're gonna navigate through it. We're gonna do it kind of the same way that we did the ICD. We're gonna practice in a page in a little bit, in a in a in a web page, but you can always follow with the book if you have them. So I know a few of you already went already to get the books, so make sure you get them as soon as possible. Yeah, well, we are going to start working uh, with Cengage and the book and a bunch of other things that you require to have the book for. So again, many of the things that you are going to uh, do have a code, okay, a listed code. There's a few other ones that have unlisted code. So if you have an unlisted code, then you are going to have a special report or a copy of the procedure report in the claim, nature, extent, need for the procedure or service, time, effort, equipment, everything. Because this is a code that is or a procedure that is not coded into the book. So we don't have guidelines, we don't have specifications, we don't have explanations of it. So again, it's in a way to that we can expand things while we are still working. So not super common, uh, but it was something like what happened again during COVID. We were kind of on the fly making up different guidelines for how to treat the virus, how to testing and stuff like that that were not in the CPT codes until the next year. So again, there's rules and things for expansion. Some qualifiers, and this is the important. Whenever you're getting a code, again, you look for a code, and it was a pre-malignant lesion, so a destruction. Oh my bad. Uh, so you have destruction of a pre-malignant lesion, so something that might be cancer, you're not sure. We're gonna destroy it. First lesion. Now, what do you use? Laser, electrosurgery, cryosurgery, chemo, whatever. If the one that you use is there, you can use that one. But the first qualifier here is always after the semicolon. You need to remember that. After the first semicolon, we'll say with, without. In this case, it says first lesion. If you have a second lesion, okay, or a third or a fourth, all the way until 14 lesions, okay, each you want to list this number, okay, that has that plus sign there. That means that this is an add-on code. So this is the original, and this number, because it has a plus there, you don't have to put the plus in the at the form. You're adding this one for every lesion, okay? So you have to put that. But because it has a plus sign, that means that you cannot put that code by itself. That code has to be accompanied by something else. And that something else usually is a code that is, again, a few numbers away from it. You see, the difference is 3 numbers here, 0 and 3. And it will tell you, what it is, okay? So again, if you select this one first, then it's wrong, simple, no payments, So again, a question could be, let's say, cryosurgery for destruction of pre-malignant lesions. And then how many you had. Depending on how many you had, then this is for the first one, then this is second, third, and you keep adding the same one. Again, not super complicated if you understand how they are and how it works. You should be able to get the codes, no problem. 6 sections is the one. That's not that you have to memorize that. Okay, so we said that the codes are going to be in the index in alphabetical order. Main terms and indented terms are going to be in alphabetical order. Main terms are going to give you procedures or services. The actual procedure, surgery, the actual procedure, bandage, whatever it is. Or it will tell you the organ or anatomic site. So if I go and say apply a cast in right leg, then the main term is cast, application of a cast. Where in the leg, okay? Or the condition could be broken leg, so fracture of the leg, so fracture of a specific bone. So those main terms is what you need to do. You need to check from the story what are the important terms that are gonna take you to the index and take you to the actual code. But every single story will have, of course, you're gonna have some main terms, but also gonna have things that are gonna be modifying terms. Okay, so if I say fracture of an ankle, a modifying term could be left or right. Okay, and those things are a matter. Okay, or with or without, and then you're gonna have the term again. It's a numeric 5-digit code, or you're gonna have a parenthesis where you have a code 11111 separated by that, or a comma, and this is a range. So this is from 11111 to 11112. Or no, it's not 2. Let's do 5. 5. So that means that any number in between 1 and that ends in between 1 and 5, it's an option. If it's a comma instead of a dash like this, then it's either the one that ends in 1 or the one that ends in 5. So again, those little things you're gonna be get used to it as soon as you start practicing, and then a few other techniques that I'm gonna show you to get the codes faster. So we said last time, it depends on the book, depends on what book is referring to this. They're gonna tell you how are you gonna get the codes. Okay, so the codes you're gonna get them by, kind of a few instructions, right? So I always tell you guys that reading the instructions of the CPT coding manual, it's kind of a one-time thing. It's what we do here is, the practice and I explain how it works. If you read the introduction to the CPT manual, one of the things that the CPT manual instructions or introduction is going to say is that the CPT code stands for current procedure terminology, and that it's published and maintained by the American Medical Association, and that it's every year we modify it, add, change, and delete some codes. That doesn't work for you to get a code. So that's we can not use that as a first step. And then it says review the guidelines at the beginning of each section. Again, not necessarily important for you guys because you're gonna do only review the ones that you need. And then here's where we could start. Okay, review the procedure, services, and documented in the source document. So you get from the doctor, you get the doctor notes, you get the operator report, you get a super bill, you get an encounter form, you get something that says this is what we did to the patient. And with that information, now you go and look at the index. Go to the index, and then from the index, it will give you using the main terms, it will give you a procedure. So you go to the procedure, go to the subterms, and now get the code. What are the code description? Does it apply to what you're doing? You compare it again to the source document, and then 7, boom, that's the code. Excellent. But you're not done. You have to review the CPT appendix. So you go now to the actual number in the book, and then check that it's correct. And then if you have to add any modifiers, you add it at the end. Remember, we went over all the modifiers, and we said that modifiers are codes that have 2 digits They could be alpha or numeric, so they could be both letters or numbers, and they're going to be added to it, and they're going to change what the code, the payment for the code is. We're not gonna do this completely. Again, not everyone has the book, even though we can do a little bit. But look, if you go from here and it has this number, so 11730-11732, that means that it's a range. So that means that 11730, 11731, 11732 are options. Different from this one that says 117 20 and 117 21. So that means that even though it's a range, but it's saying that only those two could be. So it's not a range, it's just like that code and the other code. Now, this happens to be back-to-back codes, but it not necessarily is like that. So again, this is kind of an example of a review of the CPT index, which will be reviewed in the coding manual to select for a code for nail biopsy. So now you go here and it says nail. So you get the important terms are what? Nail and biopsy, right? So the main term is nail because we're talking about what part of the body, and it's telling you what happened. Or you can say the main term is biopsy, and then you can go from biopsy to what the part of the body that is nail. So either or will work. So you can go from biopsy to nail, from nail to biopsy. But nail, as is shown here, you go to the N because that's how we're doing this in alphabetical order, and you go to nails, and then the nail part is done. So now let's go to biopsy. Biopsy is here. Boom. There's only one code and one code only. Okay. So if you were to have this question on the exam, then you will select that the correct answer is that one. Yes? No? Anybody else has any questions? Chat? Yes? Yes? Everything good? No questions? Okay. Like that's as simple as I can show it. Okay. There's no fancy tricks here. Okay. I could say something like, okay, so now instead of a nail biopsy, I have debridement of a nail. Okay, so nail debridement, then you go to nail, you go to debridement, and there's two codes. So because I have two codes, even if I have one, I should go now to that code in the book, to the 11720, and say, hey, this code, let me see if it works for what I want. Okay. So again, simple. I'm giving you the rules on how to read this dictionary. And here we go. We were right. The code was 11755 because it's the only one that includes nail and biopsy. Okay. Now, there's some other codes that have more explanation. They're longer sentences, not even phrases, and you have to make sure that you get it properly. Modifiers, we already talked about modifiers in the last class, so we're going to talk a little bit more about them. Modifier is a code, okay, an alphanumeric code. So it means that it could be numbers and or letters. It's a two-digit alphanumeric code that we use in order to clarify, change, diminish, augment the procedure. Okay, so if I do a procedure, and this is a perfect example of we do something in both sides of the body, it needs modifier 50. So that means that we did it bilateral. If I put that same code 27580 twice, then it might be reported as a duplicate, and they can deny both of them. So if you put one number and then you put the modifier 50, that means that you did it in both legs, then it will get paid double. Okay, so again, this is kind of one of those that it's simple to understand. Any other modifier that we use, it will have its own explanation. We went over all of them last class. And some of them will have letters, and the letters usually are for anatomical specifications. RT is for right, LT for left, and many others that will give you a sense of anatomical direction. So again, this is kind of how we're gonna see the examples. I don't want you to read a lot into it, but if you are kind of going crazy about how the exam is gonna be, this could be a perfect example of a question. So again, I don't expect you to know the answer yet, but just know that, look, it starts talking about routine preventing annual examination of a 72-year-old new patient. CPT code is that one. Excellent. So that means that if you go to that 99 code, it is preventive annual examination. Okay. During the examination, the physician palpated an enlarged spleen. Jesus Christ, something came out of the examination, not a routine anymore, but you did the routine. So now something else appears. So what do we have to do? So we are going to do that one, and then it says which require office or other outpatient evaluation management for a treatment on something else that same date. Okay, so now we go like, okay, we're gonna assign a 99 to 14 again for level because it's super complicated. And then we're saying, wait, you have a new patient visit here. That is this one. This is better. We have a new patient visit. That is that one. This is an established patient, and those two are occurring on the same date. That doesn't fly. Okay, this is the 99387 is the routine preventive annual examination for a new patient, and the 99214 again you will know later, but you should know by now that 99 is evaluation and management, 2 is outpatient, and 1 is for an established patient, an old patient, a patient that has been there before. So that patient is not new because you already reported something else. So it is established, but it's on the same date. And then the level is 4. So now we're saying, hey, what happened there? Because if you see this in a claim, you see the 99387 and the 99204 214, you can say, okay, Dina, there's something wrong, you're duplicating things, or you have a simple modifier that's gonna go here, and we're gonna pick which one. 22 says increased procedure. No. Number B says unrelated same physician doing post-op. This is not post-op. This is a routine preventive exam. C says 25, significantly separate identifiable EM service by the same physician on the same day of procedural order. That kind of sounds good. And 33 says preventive services. So we're not preventing any service, we're not preventing anything. We just found out that he has something else. So it will have modifier 25. Okay? So we did 2 things at the same time. So we have 2 codes, but in order to give the extra explanation for the 99214, we need to say, hey, it was something else. We found something else while we're doing the examination. Almost for sure that claim will require for you guys to send the documentation of what happened that day for that claim to get paid. So that's kind of what I should say here. So 25, yes, and it says, it doesn't say here in the bottom, but in practice, they will ask for those doctor's notes for 2 reasons. Reason number 1, most of the level 4 examinations will require documentation. And of course, if you have 2 codes, the same day, even if you have the modifier to evaluation and management, they will require you to send the codes. And again, that's something that you should know by now, and you should send the doctor's notes with the claim before anybody asks you for it. Now we go to the evaluation and management part, and this is the one of the ones that we went over. It is one of the first. It's not one of the first. It is the first section of the CPT code, because it's the one that handles evaluation and management. Evaluation and management. It's the first thing that we do when we get the patient, or the first thing that we do is evaluate. Okay, and then after evaluation, we figure out what's wrong or what's not wrong, and then we manage what are we gonna do about it. Okay, so again, it's really important that you know that the most money that comes from a doctor's office, hospital, comes from evaluation and management. Um, Again, you can do a surgery that is $1 million, but you're not doing, $1 million surgeries every day. But what you're doing every day is seeing patients, evaluating patients every day. So most of the money, again, comes from that. So you should take that into account and know that this part is extremely, extremely important for reimbursement. So again, where are we gonna get the information? We're gonna get the information from the patient. We're gonna ask them. So we're gonna have exploration part of the evaluation. We start asking, hey, what happened? Why brings you here? And that takes time, and it's part of the time when we're measuring time spent with the patient. So the doctor asks the questions, the medical assistant, the nurse, they ask the question. We try to figure out what's happening, and then we use that information to create a diagnosis, and that diagnosis, we figure out how to fix it, management, boom. That's a whole visit: evaluation, diagnosis, and then management. So there's some things that we might need in the middle of it, so diagnosis tests, some surgical procedures or whatever, and those that accompany the evaluation and management are gonna be coded separately. So it's kind of like going to uh, a hotel and paying for the room, and then asking for a room service. That room service should be extra. So anything that you do extra for the patient, you have to code it and bill it separately. So again, if you do 3, 4, 5 things, those 3, 4, 5 things have to be coded, because if not, you cannot build them. So again, some things are gonna be included. So like after surgical procedures, the post-ops are gonna be included. So even simple procedures, you get stitches. To put the stitches and to remove the stitches is the same thing, or it's considered the same procedure. So the procedure starts. You put the sutures, and then you remove them when they're ready. It happens to be 7 to 10 days. Then 7 to 10 days, you remove it. But where the intention is that it's paid in full, so you don't have to charge twice. So usually, what many minor surgeries do is that they have what we call a 10-day global period. So that means that after the visit, 10 days later, uh, they after 10 days, they if they don't come back in those 10 days, kind of on them. But if they do, it's part of the same procedure, so you cannot charge them again after those 10 days. Then you could. Now it's correct practice to remove sutures between 7 and 10 days. So if you're removing sutures on day 11 just to charge them, that is abuse. That is not following the proper guidelines, and it could be a lot bigger than the $100 that you can get by seeing that patient a day later. So again, just think about it. If you're trying to do things to get more money, then it becomes uh, abuse. Okay, so I love this part here. This is something that there's a lot of questions on the exam on this. So you need to know a few things. Number one thing that you need to know is that there are, again, it says 3 and 5 levels in the evaluation management. And again, levels of complication, of medical decision making, of how many questions they're gonna ask, how many diagnoses you have to come out in order to get a specific level of care. So uh, it becomes problematic if you do not know the guidelines. So these are guidelines that you should for sure see. So let's say 3 and 5 levels. There's levels 2 and levels 1 that they're not used that much, but they're gonna be there. Number one thing that you need is you need to document, or the documentation has to reflect that the level of care that you're giving, it's what the patient needs. So more or less, no, it has to be specific. So if you don't have enough support in the documents, then no payments. I cannot overstate that. So one of the ways that you can think about it, and I already show you a few examples. For outpatients, the numbers are gonna end in, so the first numbers are gonna be 99, then the 2, and then this next number here I want to put in a box. It could be 0 or 1 for new or established, and then the last one that's gonna be that box is gonna be 1 through 5, for example. Okay. Now, if there's some combinations there that are not billable, but so a 1, it's something that happens in around 10 minutes. A 2 is something that happens in around 20 minutes. A 3 is something that happens in around 30 minutes. A 4 is something that happens in around 40 minutes. And then 5 is something that happens in more than 1 hour, so more than 60 minutes, so 60 minutes plus. Okay. So if you are interviewing a patient and doing an evaluation on a patient, and it takes you around 30 minutes, then it should be a 3. But it does not take you 30 minutes. There's some other things that go to it. So if you have 1 or 2 conditions and they're kind of related, that kind of seems like a 3. You have to ask a few questions. You have to check a few of the systems. But if you have 3 conditions, and then I have to check 3 or more organ systems, and then you have medications, and then that could be a 4. If I'm planning a surgery and I have to check all of your systems, even if I'm planning a surgery for your leg, I need to check your heart. I have to do an EKG. I have to refer you to a cardiologist. I have to, there's so many things that you have to do, and then plan the surgery and sign the consent and all the things. Yeah, that sounds like a lot of time. So yes, that will be a level 5. Okay. So how complicated are things, and how complicated the medical decision making is taking into account when we are doing evaluation and management codes. We're using those codes. So again, it's simple enough. You're gonna find out if the patient is seen at a doctor's office or a hospital, and those codes are gonna be different. If the patient is a new or an established patient, those things are gonna be different. And then we're gonna check for level of care, and then we're gonna say how complicated it is, and follow guidelines, and boom, we should get it. Again, we're not gonna do all of them here, but I want you to start looking at things that you might need. So this is a lot of words. So what is the number one thing that you need to get? Well, think about it like this. So you have words that are important. What are things that are important? Well, you can look at the options. The options say 99, 99, 99, 99. So with that, I'm telling you that for sure, this story is an evaluation and management. Okay? And of course, look, evaluation and management. Okay. Then it says the patient. So you can go here. So that's 2, So that's not only evaluation and management. It's an evaluation and management of an outpatient. Okay. So in somewhere in that little story, it has to say that the patient was seen in a doctor's office or a clinic. And you start reading 54-year-old established patient. That's important. Established is important. Was seen at the office. Okay. So now we have, and we can construct this. It's an evaluation and management. It's a 99. The patient was seen in the office too. And then it says established patient. So now you need to know that in this case, in doctor's offices or outpatients, 99.2 is for outpatient. The next number, the next digit, is going to be either a 0 for new patients or a 1 for established patients. So it says established. So you know already that that's a 99.21 something. We're missing the last digit. Okay? So now look at the options. You have one that is 99.203. It cannot be because that 0 cannot be. Same thing in the bottom one. So it cannot be a 99.20 something. So in the exam, you can already say those two are not the options. So let's see. And we start going. Again, I don't want you to read the whole thing, but it says, hey, the visit was 40 minutes. And again, depends on a few other conditions, but 4 seems about right, because it's 40 to like 49 or 59 minutes. 5 will be for something else. So 99.214. Okay, that's kind of how you do it. Again, we're gonna practice a lot more on this. Anyone has a question on that one? Anyone has a question on that one? Oh, the book says 15. Let's see.
No questions.
Well, there should be a question because the book says 15. I didn't read the whole thing. Well, maybe with documentation, let's see. The patient has 3 4 things. Let's see how many things the patient has. Diagnosed with high blood pressure. He lost 50 pounds. Still high. There was treatment that didn't work. I kind of disagree with the book. For sure, it's going to be a 99.214. 99.213 will not be paid at 40 minutes and just one diagnosis. Okay, so here are asking some questions. No questions. Oh, there's a question there. What is the first 2 stand for? Okay, so 2 stands for outpatient. So like it was office follow-up. Okay, so 99 evaluation management 2 outpatient. It could be 3 and then 4, and could be inpatient. It could be hospital visits. We're gonna go and see all of them. So before we move forward, I want to see this. I want to check something. I want to show you something. And this is how the book says something. We can always check. So we're gonna check. We're gonna go to cms.gov. I'll show you this right now. So, again. Okay, so we are here. Based on that little example, it says 99.215. All modifiers. What we want is pricing information. Let's go. There you go. It's 40 minutes. But the book was right. So what is 4 then? Just so you know, I've never seen a 5 being paid for 1. That's messed up. It's just 39 minutes. Okay. Kind of agree, kind of not agree. I've never seen 1 paid. Who's that I just got here now? Let's see, who is it that I don't have in my list? Christian.
I didn't just get here. I just switched from my phone to the computer. That's all.
So why would I have somebody else?
Oh, okay. I thought it was me because as soon as I did it, you said that.
I did? No, 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 no. I know it's that is that I had you twice. That's it. Yeah, it was you.
Right.
It was you.
I
It was you. Yeah.
I ended the other one and I joined. I was on the phone, so I went from the
That's
phone
okay.
to
That's
the
okay. No, I
computer.
have you. I have you. I did it the old-fashioned way, and I wrote your names in a little sticky note. Yes.
Oh, okay.
And I go like, hey, why do I have more people now? Oh, well, that's good. Okay. So, look, that was a perfect example of something that you can that we need to check. So we're gonna finish this a little bit more because it looks like it's kind of specific, but you know, again, we're doing wait, this is one. Why is this going down where we were? There you go. Okay, so here's what we're going to do. Next section, anesthesia. Okay, so I want you to start thinking now that every procedure, okay, that we use for anesthesia is going to be accompanied by a surgery. You cannot give people anesthesia and not give them a surgery. I don't know if that's, I mean, self-explanatory. Okay. Um, Now, what type of anesthesia you're gonna get? It depends on the surgery, not the other way around. You're not gonna get the anesthesia, whatever anesthesia you get, that's what you're gonna do. You're gonna do a surgery, and that surgery is gonna dictate what anesthesia you're gonna get. So, if you do a surgery, you are going to, that's gonna dictate what anesthesia code you're gonna use. And it's super interesting and it's super simple. You ask what um, surgery was done, and that's the anesthesia that goes there. You don't look for anesthesia codes. You look for surgery codes under anesthesia. So it will say anesthesia for whatever, open heart surgery, whatever it is, and it makes all the difference in the world when you understand that. Most of the things that we're doing here, they are specific to something. This is specific to surgery. So you're gonna have local anesthesia. You're gonna have like this. Better. You will have local. You will have or you can have local anesthesia, regional anesthesia, epidural for all females that have delivered babies. Not all that have taken, but again for pregnant females, epidural for delivering the baby, general anesthesia, and anything else like monitor anesthesia care. So they're all different, and you cannot pick which one you are going to get. It depends on what surgery you're going to do. The easiest way to know this is you are going to uh, follow the surgery. So many of the students, when they're looking at examples, they're like, "Well, but uh, it doesn't say how many what anesthesia it is. Well, but it says what surgery it is." So that's what you follow. Uh, Anesthesia could be given by different people. So it could be an actual doctor, anesthesiologist. It could be a certified registered nurse anesthetic, or it could be the actual surgeon. So there's 3 options there. So there's not only knowing what condition the patient had, what surgery we're going to do, is who administered the anesthesia. So again, it becomes kind of a different situation when we do anesthesia. But again, just a little bit more. So because we have different things, so we need to figure out, what first check what the anesthesia is given for. So the codes are assigned based on uh, the the anesthesia administered during surgical, radiology, burn, excision, obstetrics. So surgery, anesthesia during this type of surgery, C-section. Well, anesthesia during obstetrics, anesthesia during a broken leg, orthopedics. Now, can you have multiple anesthesia? Yes. Multiple codes? Yes. Why? Because again, anesthesia could be different. So maybe you were doing something, you were doing surgery, and something happened, and the patient needed more anesthesia, less anesthesia. They woke up, they died. We saw a bunch of things can happen. So now we need to know, um, why are we doing more or a different anesthesia? And again, sometimes when we're doing multiple procedures, we require different anesthesia than if we were doing the procedure by itself. Some other qualifying circumstances is, again, what make the anesthesia or the procedure last longer. The patient was bleeding, the patient coded, whatever it is, like anything that happened. But all those things are going to be documented, and you can, for most of the cases of anesthesia surgery, uh, you need the uh, the the operative report and subsequent notes, progress notes, at a minimum for you to get paid. And our friends, the pesky modifiers, if you have something to change in anesthesia for whatever reason, anesthesia started and then stopped, the patient got an adverse reaction, stop, whatever it is, either to pay more or to pay less, we will have modifiers. And the only thing in CPT codes that has something else attached to it is anesthesia time. So how much time was the the anesthesia given to the patient, and it's going to be in time units. So it's going to be a little bit different than everything else. That's the only one that has some numbers. And the way we're going to do it is by basically multiplying the time units by the time. And you have to be extremely, extremely specific. So, but one of the things that I want you to kind of think is, what are we going to do based on what the thing is? So, again, we're gonna go over all of them later. So let's move to this one. This is the part that gets everyone scared. Surgery. So surgery section. The surgery section is the biggest section in the CPT book. It's organized by body systems. So you go through all the systems. And again, here a little bit of anatomy for you guys. Systems are cardiovascular, respiratory, digestive, urinary, nervous system, and then there's depends on the book. It could be between 10 and 12. So every single part of the body is part of a system. So whenever you're looking for something, then you go to that system. Uh, Musculoskeletal system talks about broken bones, bruises, uh, anything else that is in a body system is gonna be there. Now it's gonna be divided then into the subsections and headings and subheadings of the specific things that can happen to that body system. And when you're doing surgeries, kind of this is the way that you should do it. So 1, 2, 3 punch. What body system was involved? What part of that system was involved? And what procedure was performed? So let's do, we're doing open heart surgery. Okay. What system? Cardiovascular. What site? The heart. What type of procedure? Open heart surgery. Okay. So if you think about it, you can narrow it down by saying what part of the body, what specific organ in that part of the body, and then what was done to it. Surgery, because you had a broken ankle. So what body system? Musculoskeletal. What anatomic site? The ankle. ankle, specific bones, and then what type of procedure, and then you go whatever surgery we did to repair that. But now, where are you getting that information from? Because that surgery was done probably really far away from where you are. You just get the information in the operative report in the documents. So now you have to see more what was the procedure that they did and how they did it. So that's what is a surgical approach, and then the type of procedure. So it becomes a little bit more complex, but still you just follow the kind of the rubrics, and you should be able to understand. Now, I already mentioned this a few times. This is called global procedure, complete procedure. So the surgical packet is kind of the one that your book is using. So surgical packet, complete procedure, global procedure. These are all synonyms. This is the same thing. So global surgical package, global procedure, or complete procedure means that the patient is, or the insurance or whomever is going to pay, we are going to charge them for the whole thing, from the pre-ops, that's the evaluation before the surgery, for the surgery, and for the post-op, for the whole thing, for the whole three things together. Okay, and then including anesthesia and everything else, like the whole thing that we need. So because of that, then I cannot charge evaluation and management before the surgery, then the surgery, and then evaluation and management after the surgery. Because if you do that, then the pre-ops, the post-ops are going to be denied, or even worse, the surgery could be denied because you charge for other things extra. So it depends on the specific insurance, but it could be anywhere from either 10 or 19 days, okay, or 90 days. So 0 means that there's no global period, so you can see the patient next day, nothing happens. 10 days, like the example of the sutures, and then for bigger surgeries, 90 days. So you're gonna see the patient for 90 days after surgery, and we're gonna consider that normal, uncomplicated post-op care. Okay. We did the pre-op before the surgery, we did the surgery, and anything that happened during that surgery. That is the surgical package. One payment for all of those things. Simple, maybe. Surgical package, global surgery, complete procedure, global period, surgical package, all those things mean the same. Yes, no, maybe, questions? My chat. Where's my chat? Where's my chat? There you go. Okay. Good. Now, what if they are not a complete procedure? What if it's not a surgical package? What if it's not something that is one thing that covers everything? Well, you might have things that are called separate procedures. Okay, and separate procedures could be built together. So I built one thing completely different from another one. I did two different things. I could check for those two different things. Now, they could be things that were performed independently, or things that are completely unrelated. So you can charge them separately. Now, the problem is that some, for example, if you think about surgery, anesthesia, cutting open, doing the surgery, and then closing, that's all part of the procedure. So you cannot separate the cutting, the suturing, and doing the surgery. It's all the same thing. It's all one. But if things are completely different, then of course you can do it as a separate procedure. But if you're separating the procedures on purpose so you can get paid more, then that is abuse. Okay, you're doing the things, but you're charging them differently to take advantage of the system. Abuse, and usually they don't get paid. So it's called unbundling. unbundling, you're separating the procedures and charging them as separate procedures, and that will get you in trouble. Now, this is the best example of separate procedure or multiple procedures. So 2 or more surgeries are performed during the same session. Okay, one is a major surgical procedure, and then we're gonna do that one, and then the second one that is a lesser procedure, we're gonna do it in a different line in the same block 24A. So that's the CMS 1500 form, and again, this is the part that matters. We are going to bill for whatever is more expensive first, and then whatever is a lesser cost second or last. Okay, so it's gonna go in descending order, most expensive to least expensive. Now, if we need modifiers, an example of a modifier that we will need here is 51 added to the lesser surgical procedure, unless, okay, we have the no or the plus in front of the code. So if there's a no or a plus, then that you cannot use those, and you can use the modifier. So again, this is saying the same thing, ranking major or minor procedures. Simple. You go and check which one is going to pay more. The one that pays more is the one that goes first. The one that pays less is going to go second. But remember, the second one is not going to be completely separated. So the anesthesia, the thing, you cannot get paid for the complete procedure because you did it at the same time. So it will be a reduced fee. Again, you go to the mechanic and they change one thing, they're not gonna charge you for every time the car went up and down the hoist. Like, no, one time it went up, and while you were there, you did something else. So it should be cheaper than if you go one day and do one thing and another day and do the other thing. So again, it's usually better for the patient, better recovery, more convenient, and better for everyone involved. And then for the insurance company, then less payments. Radiology is anything that has to do with imaging. So diagnostic radiology, X-ray, ultrasounds, radiation oncology, nuclear medicine. So it's not only imaging, but imaging and some treatments. So usually view is the what we're looking at, we're thinking when we're talking about radiology. But it has a few things. So to keep it super simple, like everything else, my bad, is divided into anatomic sections. This is horrible. Anatomic sections. Okay, so it's going to be per section, and it's going to be divided that way. So the images that we're going to get are from different parts of the body, so it's gonna be divided like that. So another thing that we need to know is the views. How many views? Okay, and views are gonna be taken from different angles. You can have something that's called PA or something that is called AP. Okay, so you're doing a radiology of the chest. PA means from posterior to anterior, so from the back to the front. So it goes from the back and comes out the front. Okay, and if it's backwards, then it comes from, let's do it backwards, but anterior posterior. So it starts in the anterior, comes out in the posterior. So again, just to illustrate what we're saying, it would look kind of like, oh, that's the same thing. I did it wrong. Anterior and then comes out the posterior. There you go, like that. Okay. I can have a lateral view. I can have an oblique. So it could come from the side. It could come in an angle. We have specific views for specific parts of the body. Different parts of the body we might get more parts. So all those things you need to know. So again, but that's going to be given. Example, I have next. And again, sometimes it's complete. Some parts of the body will have different views, and in order to see the whole thing, you will need different views. An example of that will be your ankle, your vertebrae, and your wrist, and you have different view. You have from the side, you have from the top, you have it in an angle, you have in specific weird angles. So all of those are going to be included. Oh, wait, this was the question. Patient underwent two view. Okay, so two view. Posterolateral, so from the back to the side, chest X-ray for probable pneumonia. So they did one from the back and one from the side. And what code should we assign? I mean, again, these are the codes. You can just go in the book and read them, or the examples are here. Single view, no. We got two view, that could be it. 3 views, no. 4 views or more, no. So no, no, no. Right one. And this is how you're gonna answer questions on your exam. This is how I want you to answer the questions on your exam. If the question says information like that, like super simple, then you get it. It says 2 views, 2 views. Now, what the other ones cannot be? Well, the other ones cannot be because one says 1, 3, or 4. Boom. It took us 30 seconds, less than 30 seconds to answer that question. And you don't need to know what the actual codes mean, okay? So not necessarily you need to know that. In the exam, that could be a question on the certification exam. Yes, no, maybe. Ivo, you there? Hey, chat, going crazy? No, just one in the chat. Some people are putting faces and saying no. Good, thank you. Yes, we're here. Okay, excellent. Now it went crazy. There you go. That's what I wanted. Yes. So again, I'm not doing this once yet because for that I want everyone to have their books. We're gonna talk about it in a little bit about the book, who has them or not. Okay, so medicine section is the last section of the book. It's classified into two parts: non-invasive and minimally invasive. Non-invasive means that things are not cutting into the body. Minimally invasive are things that are cutting into the body, but just a little bit. Minimally invasive will be something like an injection, like a vaccination. Non-invasive will be everything else, like a cast, wraps, anything like that. So it's gonna be divided into those sections, and then it's gonna be divided into the procedures and the medical specialties. So again, if we don't cut into the patient, non-invasive. If we cut even just a little bit, then it means that it's invasive. Invasive, minimally invasive means vaccinations, injections, stuff like that. Subsections will go to procedures. Example of the procedures could be vaccinations or immunizations, or the medical specialties. So some things are going to be like specifically of a specifically of a specialty. So it will start, by specialty, and then a few other things that we have. Physical or occupational therapist codes are going to be there. So again, anything that is not a procedure, anything that is not a surgery, an evaluation management, radiology, anesthesia is going to be here. So whatever is left over. Again, a patient was treated in the ambulance, received a cardiopulmonary resuscitation, CPR. Which code are you going to give? So again, without knowing a lot of the things and without having half of the information that you need, then you have to get the code. Again, you have the codes here. If you get to a question that you don't know, the information here is not enough, you can always go to the book and start looking for those codes. Okay, 9295 here. Okay, and you look for them. So let's see what the okay, cardiopulmonary resuscitation. Because it says only cardiopulmonary resuscitation, not giving you more information. So you do not add or subtract information. That's what it's giving you. That's the one that's there. Then yeah, that should be simple. That's the one that you select. Let's see real quick the other options, just for the purpose of showing you how to answer questions. Okay, look, this one says cardio Jesus Christ, my bad. There you go. This one says cardioversion. Does it say cardioversion anywhere? No, it says cardiopulmonary resuscitation. If you go to the code and says the cardioversion is the same as cardiopulmonary resuscitation, then you could use it. But then it starts giving you a selective electrical correlation for arrhythmia. It doesn't say anything on there. So not that, actually not that, nothing. It cannot be. Now it says internal separate procedure. You don't know. It could be if it was a bigger story and it'll tell you a little bit more, but it's not telling you that. So again, how could it be a separate procedure if we're only talking about one procedure? So nope, cannot be that one, cannot be that one. And then this one says level 3 EM office or other outpatient service. And if you are a good student, you should know that evaluation and management is going to be at 99, at 203, and that is a visit. So it says there, that's a visit. Here it says they gave the patient CPR, so no visits, no nothing. Yes, no, maybe. Whoa, Parker, what happened? Can you go back to?
Oh no, you're fine. That was.
Is this one?
That was. Yeah, no, it was before, but it's fine. We didn't have the code for it, so I was wondering where you got the code from, but you said we didn't have it, so it's okay.
Yeah, of course. That's kind of the thing. Like if you have it, if you have books and you have everything, we'll do it. It's not yet. Okay. And then the last few things here, it's the category 2 and 3 CPT codes. Okay, so CPT category 2, they're gonna be supplemental codes for tracking performance of the providers, of the hospitals, of everyone. So, or information, or how many, for example, I could do it for statistics. I can say how many people are getting open heart surgery. Well, and we track with using those codes without having to check on everyone's medical record. So it's kind of a easier way of checking what the things that we're doing. And then 3 are again temporary codes that are gonna be used for emerging technology, things that are new, things that are might stay for a while, not for the rest of the time, or are going to be a CPT code. So we have both. I'm pretty sure I have one from 2014, 15, around here, that has a bunch of weird things that back in 2015, unless actually if it's 14, it was 13, so it's 10 years ago, that we thought that they were gonna be something, and they didn't. So they were in the code book for a little bit, then we didn't use them and they went away. Again, when we get the books, you're gonna be able to do this. But look, the codes that we've been showing you so far, they were 5 characters long, 5 digits long, but now this codes have a letter at the end. So that's how you know that we're not using the CPT category 1s. Okay, again, we're gonna do this later. I mean, we could, let's try it. Patient underwent community-acquired bacterial pneumonia assessment. Code is assigned. So what are the main terms? Community-acquired bacterial pneumonia, and it was an assessment. Come on. Community-acquired bacterial pneumonia assessment. Is it clearer than that? Now, again, it's not saying anything else. Could it be comorbid condition says? Yes. It could be vital sign reported? Yes. It could be whatever. But here it doesn't say that. So we should, if it's not trying to trick me, we should say that the one that has all the words that we have in the top, maybe acquired bacterial pneumonia assessment, that's exactly what it says here. So that's how I want you to get it. Like exact numbers in the exam is gonna be like this. It's gonna give you really exact things. And again, self-assessment where you're able to apply this. This is for you guys, but we need to go to the book, and that is this. Okay, let me stop this share real quick. Do we have more people? We do have more people. Who is here that was not there before? Because I am my trusty Andrea. Hello, Andrea. I mean, it might be wild there, but I just saw you there. Hello, hello, Andrea. Maybe she wrote already here and I didn't pay attention to it. If you did, and of course you did, I'm so sorry. Okay. Quick question. Yes, hello, I'm here. Yes. How many of you have your books? How many of you don't have your books? I need yes, no, I need chat. Let's do chat. So it's Lane. Andrea, no. Oh. So Andrea, no. It's Lane, yes. Candace, yes. Mika, yes. Frank, yes. Frank Jr., yes. Yaeli, yes. Christian, yeah, 4. There's 5. Frank Sr., yes. Christian, there's 5. Do you have 4 just because they gave you 4, or? Okay. Who else? Yeah, there's 5 books. So you have, okay. Okay. So there's, so you have, at least you have this one. You have the one from the one that we're doing the class now, the one that looks like this. You have this one, the understanding thing. Those are the ones that come in 2. For the people that only have 2, that's what you have. I'm sharing my screen now. Okay, perfect. So that's what we need to start. Yeah. Okay. Let's see, who else? Let me stop here. This looks better like this. So Parker, Christian, Mirta, you answer. Okay, so we're doing good. That means that a few people have it. Andrea was the one that said that she was okay. You're gonna get it tomorrow. Okay, so that means that by Monday everyone will be or not everyone, but at least everyone should have that book and will be able to log into Cengage. So we will do that on Monday. We'll log into Cengage. That's a thing that you need to do some of the assignments. If we cannot get it working, we will have we'll do it without it. Do I need to go back and get other when all the other books are ready, they will call you. The thing is that I think they were on back order for a little bit, and I don't know if all of you have all of them, but yes, they'll let you know when they have. And those books that you're missing, every single one of you has to have it. And when we have those, we'll be able to go and register for the NHA exam. And then those are the books that you're gonna take to the exam. So I'll let you know which ones are the ones that you're gonna take for the exam. Okay, so that's kind of the plan. I don't want to go and do the next chapter now, it is a kind of a shorter chapter, but what I want to do is for a couple of minutes, if you allow me to, I will show you kind of the same thing that we had last time, the icddata.com. But now we're gonna change it to the CPT or HickPixData.com. Let me know when you can see my screen.
Yes, we can see.
Okay, thank you. So this is a little bit kind of like what we saw before, but these are the HickPix. So this is the next chapter that we're gonna cover. So we have HickPix, and the codes are gonna have letters. So just remember that the ones that don't have letters are gonna be the CPT. So again, the ones that have letters are gonna start with a letter or end with a letter, and they're gonna be for different things. And if you think about it, the way that I described the CPT codes, I said evaluation management, surgery, anesthesia, or evaluation management, anesthesia, surgery, radiation, and medicine. Everything else that is not any of those things here. Ambulance ride, for example, it's here. What type of ambulance ride? In this case, it says Medicaid only. Let me do this one. What type of ambulance ride? Non-emergency, transportation per mile, volunteer, like all the, like this is to give information on the things. Okay, look at this: non-emergency transportation or wheelchair. Why would we need something like that? It's not payable. We're not gonna, but it's a code that is there, and it's giving some information thing. So again, they're not for all of them are not for payment, but you know, some they are. Let's go crazy and see if we can find an ambulance. Air services. There you go. So transportation in an ambulance. Okay. And it says rotary wing air transport. So that has to be a helicopter. Think about that. This is crazy how specific we can get. Okay. Again, let me see if you have the fixed wing. So again, if it's not a helicopter, we go through a plane. So how specific we wanna get? Whatever you want. Okay. So medications, syringe with needles. So again, all those things that you have to charge anyone, anything and everything will be there. Okay, and this is only the A's. So let's go next to the what it says how many codes we have for whatever it is. We have again transportation, internal and parental therapy, primary temporary codes for outpatient prospective payment services. We're gonna talk about that later. Or system, durable medical equipment, DMEs, things that you give someone for their like that is not a medication. It's just something that is medical equipment that lasts for a long time. Durable medical equipment. What are those things? Canes, crutches, walkers, wheelchairs, wheel attachments, crutch attachments, leg extensions, like anything. Power pressure reducing mattress, air pressure mattress, bathtub rail, hospital bed, bed board. Think about it, and we have it here. And it's important that you know that these things exist, because it depends on where you end up working. You might have to get them. If you work for a maker supply company, and you have to do their billing for them, this is what they're gonna sell. Okay. Look, this is a new one here in the bottom, the coronavirus diagnostic panel. So these are codes that started because of the pandemic. So all the codes, all the things that we did, someone had to charge. And look when it started. Okay, effective date February 4, 2020. Okay, so before the world, a month before the world went crazy, then we had this. But if you see the first one that we check, or one of the first few that we check, the transportation ones, it will tell you something like this. Look, the code was added January 1st, 1985, and it was effective or until 1996. Think about it, how like all the information that you might imagine that you need and why it's there. So this is a good way of looking for codes. Again, I would like you to go to this page. It's HICPICS, CPT, ICD, and just play and start looking for things to see what those things are. One more, I promise. I'll let you guys go. If it wants to open. So this is the people that we were talking about on our last class, the modifiers. Modifiers, again, different modifiers. They start with, in this case, they all start with letters, 8 modifiers, and then all the modifiers that we have. So they could start with letters and number, a combination of letter and numbers, or just numbers. You know, dressing for one wound. Think about that. If it's 2, there's another one. Like, when did it start? When did we add it? And it goes 1, 2, 3, 4, like all the way to 9. Oh, there you go. So C is for changing what the procedure has happened. So procedure code change, you see C when the procedure submitted was changed either through administrative reasons or incorrect code was filed. So this is an example of a code that or a modifier that you could put in just to say, hey, this was wrong, and I'm changing it before I'm actually submitting it. It happens a lot in hospitals, so that one is a lot. In the exam, they'll ask you what CC means, and it depends on the part that they're asking. CC could be cubic centimeter, measurement of volume. It could be cheat complaints that has to do with the subjective information on a sub note, or it could be the code change as a modifier. So that's a good one that the exam makers like to ask. And again, just think about anything that you can think about will be in the modifiers. So this is what's next. HickPicks. We're gonna see it tomorrow. Today you get an early finish to the class because we actually started it last class. Let me see here. I'm having trouble uploading the things. I don't want you to think that I'm not, or that I'm forgetting you guys. It's just taking forever. And because I'm trying to do it in a zip file, it it takes less. But so yeah, this is 31. So next class, so tomorrow we're gonna do chapter 8, HickPicks level 2. Kind of the same principle, and we're gonna show you how things work, how to use it, and then we're almost getting to the point that we need to do math. So probably next week we are going to start talking about math, about what the math portion of this is gonna look like. So I want to make sure that part is as straightforward as possible. So yes, it's gonna be probably the last 2 days of the week. The first day will be the chapter. I think it's chapter 9, and then the next 2 days, so Thursday, Friday next week, we're gonna be doing math, and then we'll be in good shape. Any questions? Anything else before I let you guys go?
So I'm sorry, I missed the last class, but I know you were speaking of an assignment that was supposed to be due this week.
Yeah, again, when everyone gets books, we will.
Okay, so we can't. Okay. I was just making sure.
Yeah, the thing is that we're gonna register for Cengage. We're gonna try to open it, make sure that everything works good, and then that will work that way. But if not, if everyone, like whenever people are missing that, yes, I have Vanessa and I have somebody else. Hello, no problem. So make sure that when we get that, we can get in, can do the things, because I know how things. I know how the computers are with you guys. Not working properly, not giving you the. So yeah. Again, homework when I tell you, and we might start homework when we start math. That's okay too. That doesn't matter. We're doing really good in time, and this is something that I want you to understand. What I want is to have the last few classes, and hopefully the last few weeks to do practice. Okay, and if you do practice, it will be to me will be the best way. So we're gonna continue with the chapters. We're gonna have 8, 9, 10, 11, 12, 16, 17, and then we have 3 more. Perfect. Like we really doing really good in time. We're gonna do 1 or 2 chapters in one of these next days because there's some tiny chapters, and then practice for the exam. Like there's no there's no way that we're not going to have at least 3 full classes to get ready for this exam. So don't worry, we're doing good. We're doing great, actually. Anything else? Any other questions? People, please go get your books if you still haven't gotten them. At least the initial ones. Make sure that you are attentive to your emails and anything that they send you from the college. And yeah, if there's nothing else, you are free to go, and I'll see you guys tomorrow.
Have a good night.
Yeah, same to you.